Our process started as a clinical practice directive, and in-health directives to change clinical processes and practice is part of our core business. How we choose to facilitate change is fundamental to ensuring standardised, safe clinical practice is implemented effectively. We chose to utilise the principles of transformational practice development that we learned through our EOC work. With our presentation, we aim to demonstrate the successful outcomes of incorporating practice development principles into the implementation of a clinical initiative that involves cross-facility participation and collaboration. While the project did not evolve directly out of EOC work, the change we achieved was made possible by our EOC participation, more specifically our experience with facilitating transformation practice development. It demonstrates the flexibility and adaptability of both the PD and EOC models. So I'll just start with a bit of background. Reverse retrieval return refers to the return transfers of patients back to their home facility same day post-procedure. And Liverpool Hospital first implemented this process back in 2006 as a response of the recommendations from the statewide Cardiology Clinical Services Redesign Project. Prior to the implementation of reverse retrieval, inpatients from the local facilities would remain at Liverpool Hospital overnight, and the patient would either remain as an inpatient at Liverpool and be discharged home from Liverpool the following day, or be transferred back to the home facility after a particular time frame depending on their clinical need. And additionally, it was also a common process for patients who were transferred to Liverpool from another district facility for a diagnostic procedure. If results indicated that they needed further treatment, they would then have to be sent back to their home facility and then rebooked at a later date. And as you can imagine, this led to patient dissatisfaction, increased length of stay, and also increased demand on our resources. So the retrieval process initially commenced at Bankstown and Campbelltown, and both these hospitals had dedicated CCUs and cardiology medical rosters, whereas Bowral and Fairfield didn't. Now, it took about 2 years for the process to really become standardised. And in 2012, the cardiovascular stream in southwestern Sydney raised the need to advance the process to include Bowral and Fairfield. And this came with new challenges and also benefits. So the initial challenges were that neither site of Bowral or Fairfield had dedicated CCUs. The nursing staff were unfamiliar with managing patients directly post-PCI. There was no cardiology medical rosters. There was a significant distance from Bowral to Liverpool, and we also needed to develop processes that improved patient satisfaction. And the benefits were that both areas were HDUs, so they had cardiac monitors. They did have established cardiologists at both sites. The nursing staff were familiar with looking after post-coronary angiogram patients, so it was a case of building on their existing knowledge, and all the disciplines were supportive of the process. So next we had to look at which site we would start with, and we decided to start with Bowral, and we recognised that undertaking a project like this, it would require adequate preparation time, and before going live it took about 6 months. This slide demonstrates our shared core values of the project. Our approach was centred around collaboration and inclusiveness, and we were very aware that each site had unique needs. Surrounding the context of reverse retrieval, we examined our core values as a leadership team, and the agreed ways of working were devised. And this was actually about putting our values into practice, demonstrating the incorporation of practice development and how it works in the real world of clinical practice. And then we had to look at our intent and what outcomes did we want to achieve, and we broke it down into 3 groups. As you can see on the slide, we started off with the patient, and then we looked at the staff, and then the organisation. We also were very mindful of making sure that the communication processes were good, so we had to look at all the key stakeholders. Communication at all levels sounds very easy to execute. However, the method and approach we take in communication is essential to ensure positive and constructive engagement. I'd now like to introduce Sharon, who's going to talk about the approach.
Thanks, Amanda. So our approach. Initially, the Liverpool project leaders met with the Bowral leaders to develop a preliminary plan to meet the immediate needs of both patients and staff. All respective staff went back to their local facilities to filter the plan. Nursing staff were informed at local staff meetings. Senior medical officers were engaged through relevant district and local cardiology business and SMO meetings. The shared ideas resulted in a starting framework that was used to guide, support, action and maintain focus on the important aspects that were associated with the process. So the original framework, the patient always remained central to our focus, and the dominant themes that emerged included patient safety, quality management, communication and collaboration, and education. From early implementation, the NUMs at both sites facilitated day visits to the cardiac interventional unit for all HDU staff to witness cases and obtain on-the-job instruction in directly caring for patients post-PCI. This provided opportunity to consolidate clinical theory into practical skill development. The CNCs with cardiology head of departments, SMOs and nursing leaders across sites supported the development of a combined policy. The practice and associated policy was also reviewed by the HDU nursing staff. The educators at Liverpool provided Bowral staff with in-service education associated with clinical management, and Liddy continued the in-services, as well as coordinated education via external sources. Now, this is a really busy slide, but it's extremely important to present because following the in-service sessions, the clinical staff in HDU identified the need to develop a clinical guidance support model in the event of a complication occurring at their site. This model provided the clinical staff a quick reference of what to do if a complication arose. The draft model was created by the educators at Liverpool and evolved through clinician input at Bowral. The model was reviewed and endorsed by both head of departments. This red flags document was also a policy appendices and was originally developed by the Cardiology Interventional Fellow for Liverpool Hospital Junior Medical Officers to support them in recognising and managing potential arteriotomy site complications. It was introduced during the reverse retrieval process as it was certainly applicable across sites. Now, over to Liddy.
So in regards to patient discharge, we developed a standardised process across both sites. We barrelised an existing information booklet for patients and their carers. A discharge checklist was included to allow for quick referencing. We emphasised antiplatelet therapy as a priority on discharge, with the patient being aware of what they were going home on, and we stressed the importance of follow-through with their local pharmacy. Cardiac rehab referral was also vital on discharge. We collected patient stories from our patients, and we collected data from our staff as well. We gathered qualitative data via patient stories on 15 patients. This was ethics approved under the EOC banner, and we used the New South Wales Health Redesign framework via telephone interview, and we gained verbal consent from the patient. We were interested in the patient experience, particularly their journey and the positive and negative aspects that they encountered. Results were mostly positive, with a focus on medical intervention and nursing care. There were some negative themes that emerged around transport, communication, cannulation and bruising issues, and hospital food. In regards to our HDU staff, qualitative data was also collected, and we used two avenues to do this. We did it through a staff survey and an EOC forum, and we were keen to gain staff feedback in the forum from face-to-face interaction to allow for better quality engagement and a feeling that the staff were being listened to. We asked our staff to comment on their initial thoughts and feelings around the project, the support that we provided to them through a site visit to the cath lab, and additional education that we provided through in-services, an education package, equipment use, and governance surrounding the project. Again, results were mostly positive, with half of our HDU staff being keen to start the project. There were some issues that were raised regarding support at the site visit. We also collected quantitative data. Results were based on statistics that we collected over a 15-month period from January 13 through to March 14 on all patients transferred to Liverpool Cath Lab for angiography. Since going live, 106 patients have been sent through from Bowral Hospital. And over 70% of those patients have returned same day. And nearly 30% of those patients have undergone PCI, with a low percentage of minor complications incurred. So this has led us to conclude that the process of same-day return post-angiography PCI is clinically safe. So I hand over now to Gail.
So, the lessons learnt. Late returns to Bowral has resulted in an inability of the HDU RMO to immediately assess the patient, as our RMO only works a day shift. So alternatively, after hours medical staff are required to assess the patient, but in most cases that's not needed. The big issue that we have found is that the Bowral staff were not informed when the patient was leaving Bowral, and they quite often were late returns. Oops, find my button. So, what the lessons learnt to what next? So, improved communication regarding transport, which is not something we're having a great deal of effect on, but informing staff and of both sites of late arrivals and late departures. We're developing a monthly communication between sites regarding issues of concern and how to manage. Utilising the generic ISBAR tool between sites for consistent clinical handover practice, and improved support from the CRU staff in providing education pertaining to effective practice. So our future direction. Fairfield Hospital have now commenced reverse retrieval in August of 2013, and the progress was replicated as the same as was Bowral, pertaining to their needs. So, and at this stage, they will undergo the same approach as Bowral has done. The next step is protocol-driven discharge for patients who have undergone PCI, which has been implemented at Liverpool of November of 2013, and that's now going to try and be implemented at Bowral Hospital as well. We need to look to establishing a formalised trialling and a standardised process in clinical handover between sites. As a last thought, a summary of our project. The PD methods we used included values clarification, ways of working, claims, concerns, issues, facilitation, collaboration, inclusiveness, and participation. Thank you.